A lot of people have insurance, but they don't have care, right? So there's insurance and
Right.
then there's actual care or actual health, and they are not the same thing. So you could be insured, but then not be able to get in to see a doctor. And how is that insurance actually working for you?
Right. This is MedSpa Mayhem, the podcast all about the chaotic world of medical aesthetics. From Botox to lasers to IV bars, learn how to tell real versus fake, legal versus illegal, and safe versus potentially deadly. Hear the crazy stories inside the med spa world and find out what questions to ask and how to spot the people cutting corners. I'm your host, Dr. Kate D. Together, we explore the wild west of medicine that is the aesthetics industry. In this episode, I'm speaking with Dr. Steffie Deeds. She is an internal medicine doctor and founder of her own direct care practice. And in this conversation, we're going to talk about what exactly is direct care and why that might be really interesting to you and what are the advantages of that, both as a physician, but especially as a patient looking for a doctor who will really actually take care of them. And then the second half of the conversation, we're going to be covering hormones and menopause from a little bit different perspective. And I hope you find this conversation really interesting. I know I did. Hi, this is Dr. D, and I am here today speaking with Steffie Deeds. She is a physician originally from Michigan, went to University of Michigan for undergrad, then went to Case Western for her medical school, and then trained in internal medicine out here in Seattle at the University of Washington. And she has a independent direct primary care practice, and she is just a wealth of information. So I thought it'd be fantastic to bring her on the program today for a little conversation. So Steffi, thanks so much for being here.
Yeah, thanks for having me, Dr. D. Excited.
So can you tell our audience a little bit about your history, how you got here, and how you ended up setting up your direct care practice?
Sure.
Because I think it would be really helpful to explain to people what direct care is and why it's a phenomenon, why are more and more doctors are doing that.
Sure. Yeah. So I'll start with just talking a little bit about how I ended up in primary care. I mean, I think I made that decision at some point during medical school, actually, that in the clinic, that I was like, wow, I really love working with people and building relationships with them over time. And so I knew that I wanted to be that health navigator, the quarterback of their healthcare team, and being their touch point throughout their life, whether things were going really well or things were really challenging, and just helping them navigate those real life health issues and how that plays a role in their overall life, right? Health is such a huge thing for life. So I knew I wanted to play that role in people's lives and work with them over time. And so I chose to do primary care for that reason. And then in working in the traditional system as a primary care physician for years, I think I discovered a few things. I mean, one, I was very gung-ho about doing a lot of improvements and making things better and like really excited to be in that atmosphere, especially as faculty working at the university here, and getting to work with students and trainees. And I loved all of that. But you just realize things aren't really going to change so much, right? There's so many people involved that we are accountable to, like the insurance, the system itself, the people in between. And it didn't take long to realize I can do a lot of improvement projects and we can make a dent in a positive way. But we aren't really going to change this behemoth or this monster that we kind of have that is the insurance system-based care model that physicians are employed by. So being an employed physician in that model, it didn't match with the type of care that I wanted to provide. And so I knew that I knew that if we kept things simple, we kind of like stripped out the red tape and the middlemen, so to speak, right? If we kind of remove all the complexity and it's just focused on the relationship between the patient and the doctor, and you really just get to work together and build that bond and get to know each other, that's all you really need. Like most of what I'm doing is listening to people and providing advice and giving my medical knowledge and pulling puzzle pieces together for them and helping them in their achieve health. And so you don't need it to make it complex, but the system has made it complex. So I think that was one thing.
Well, the system is completely broken. You
Yes.
have to definitely don't have to convince
Yeah.
me that that's the case. And I think that for most people, doctors and patients both find it absolutely impossible to navigate, right? Doesn't help to even be a doctor really to get through it. And I'm sure I think most of our listeners know, like when you go to a regular doctor's appointment and it's covered by insurance, I mean, insurance basically will not pay you to talk to patients. They won't pay you to listen to patients. They won't pay you to help people prevent a disease,
Yeah.
right? What they'll pay you for is doing stuff to the patient. So they'll pay for surgery, they'll pay for procedures,
Absolutely.
right? But it's so messed up, right? The actual doctor patient relationship doesn't exist the way it's supposed to. And my definition of the way it's supposed to is, you get to know me, you do a physical exam, you take a full history, and you get to know everything about me so that when something does happen to me, you know what to do, right? Because you have a real relationship with them. And so tell me, so you opened your own direct care practice.
Yeah.
So what I understand is like basically that allows you to have that relationship with the patient, right? I mean, that's like the whole purpose. So how did you end up doing that, and how does it
Yeah.
work?
How did I take the deep dive? Well, I had actually first learned about that this model even existed during my training. So it was years ago. And in the back of my head, I thought, well, maybe I'm going to do this someday because it just makes sense to me in my brain and how I want to work with patients. But I just felt like the timing was right. So I took the leap last year and opened up my clinic. It's been a growing wave across the country. And I saw how many other offices and doctors were leaving the system to set up practices like this, where they could really take back health for patients and doctors, right? And put the focus on the relationship. And I just felt like this is doctors taking the system back from the system and putting the control back to the patient and to the doctors. So I wanted to be a part of that. And I wanted to be able to have longer visits with my patients and get to know them and be able to see them more often if needed and just be available directly to them. So how that works is that I do have a smaller panel than a typical system. So people are often surprised to learn that a traditional primary care doctor and a system probably has on the low end 1,500 patients. So 1,500 patients to potentially 3,000 patients. And so if you wonder why you can't get in or why they don't seem to know you, if you've only been working together a short time, it's really, that's a daunting feat to know 3,000 people that intimately.
Yeah. I don't think
Possible.
it's possible,
Yeah, it's not possible.
really.
And so people get burnt out, like seeing too many patients. But in this system, I was like, I don't want to be burnt out. I want to take care of a smaller number of people and do a really good job. So really we're focused on prevention. I get to have conversations with them about how's your sleep? How's your stress? What are you doing for nutrition? How are you moving your body? And how does that work with the medicine or medical care that you need? And we can put the whole picture together and I can have those longer conversations. That wouldn't be possible, right? It wouldn't be, as you already brought up, you don't get paid or reimbursed for having discussions about things that really do matter for people's lives to feel well, for them to get better. And so that's been one of the greatest things, is just being able to bring that and really help people chart a plan for their health in a way.
Right. I mean, and all the tradition, all the places that are run by hospital administrators or clinic administrators that take insurance, like they want you to see one patient every 15 minutes, right? Which is like not enough time to do or say anything, right? Other than just get the basic, like what's your blood pressure, and there's just not enough time. They don't care if you take care of everything.
Absolutely.
Right.
Absolutely don't care. Yeah.
So you're able to have kind of long conversations. How long are your
My shortest
appointments
visits are 30
now?
minutes for follow-ups, and that's usually we're working on a focused problem or we're touching base on a plan that we've already put into place. And then my other visits are all an hour. New patients, sometimes it can take 90 minutes or 75 minutes, and I'm drawing blood work and we're getting them all set up, and those are kind of like the setup appointments. But like all my patients, they have access to me through a secure messaging portal. And when they hear back from me, right? There's not a nurse or a triage, and they're not getting through a phone tree. If they message or call me on my phone, it gets forwarded through to my cell phone, and I text them back or call them back. And just like the care is more efficient. So I think my patients really value both the access and efficiency, and they just know that they get me every time, so that the advice that they're getting is really for them, right? It's like someone who knows them each time. And it gives me the flexibility to provide care any way that makes sense. So we videos, phones, in person. And I recently, as you and I had talked about offline from this conversation, that they're going to be doing away with video visits payments. I know it's just
Craziest thing. It makes no
a
sense at
huge
all.
burden, right? It's going to even more burden the system.
Yeah.
And so the fact that I don't have to be beholden to that, right? It's if I can resolve something on an email message and without a visit, that's great. It's safe and it works. But because you wouldn't get paid for that in a traditional model, they're just going to go with wherever the payment goes. So it's really sad to see that that's what's driving care. And I think like you said, patients know that, doctors know that, like we feel it. So.
Well, just to give an example of why these things make no sense, right? Let's say you have a chronic medication like I do. I'm on thyroid medication. I've been on it for a million years. I can't even remember how old I was when I found out I didn't make enough on my own. But, I mean, basically I've been on the same dose for decades. And do you ever notice that when you go to renew a prescription, if it's more than a year old, you got to go back in to see the doctor, right? And they won't do that over the phone necessarily, right? And well, why is that, right? Because you're providing basically a refill service for free if you don't see the patient. So they require people to come in once a year to get paid this small amount of money, but at least it's not nothing, in order to refill your prescription. So you're a healthy person. There's nothing wrong with you. You get your blood drawn every year to check on your levels, but they still want to see you. Why? So they can bill for that visit. That's the only reason, right? And so after COVID, they allowed the insurance companies and Medicare, Medicaid allowed video visits, right? Like, why do you have to go in for that? Doesn't make any sense, right? We should have a video visit. And they could charge for that. Well, what Steffi and I talked about just moments ago is that they're now eliminating that as a thing you can bill for. So you can't bill for a video visit anymore. So the people who used to just do a video visit for that to get their thyroid renewed. Well, you're not gonna be able to do that anymore. You have to go in person just to get that renewal, even if you've been on it for decades, even if your dose hasn't changed now. So none of that makes any sense, right? So the maximum amount of inefficiency you can stick into a system, right? Like instead of just going in once a year for a blood draw to check your levels, and then having your dose adjusted if it needs to be and just renew it. Instead, you have to get in a car or a cab and pay for parking and take up time and then wait in the doctor's office for an hour and a half because they're running behind. And then all for what? What's the reason, right? So that because our system's broken and they want to bill for it. Little soapbox
That was a
there.
perfect
Sorry.
example.
Anyway.
That was a perfect example of how inefficient and broken things are, and why when you take out the payment piece, you can get better care.
Much better care.
I always call it, I say the care that makes sense. If you just thought like what would make sense, that's what you can do. And so I feel like I didn't totally describe direct primary care, but it's similar in what people would think of as concierge medicine. So I charge a monthly fee. So you have me, I guess, or a retainer or a subscription model. These are all different terms. I like to call it membership medicine. So people pay me a monthly membership fee. All my patients are members of the clinic, and they get all the unlimited, right, primary care access they need with me, whether that month we're working on something and we're talking a lot, or maybe we didn't talk that month, but I was available in case they needed me. And then I use their insurance to get their medications, run their blood work, consults, imaging, all of that, just in the typical way. So it's really just my time that my patients are using as part of their membership. And I don't bill insurance for any of my visits. So it's very transparent also, and helps with costs in that way. A lot of people have insurance, but they don't have care, right? So there's insurance, and then there's actual care or actual health, and they are not the same thing. So you could be insured, but then not be able to get in to see a doctor. And how is that insurance actually working for you?
Right.
And so that is a conversation I have a lot with people who,
Well, and then their doctor's not available. So where do they go when they actually need something? They go to the local urgent
Yeah.
care where there's not even a doctor there
Yeah.
usually, right? It's staffed by mid-level providers
Yeah.
mostly. And then they don't know you at all,
Mhm.
right? And then they may or may not do the right thing. I had one of my employees last year had strep throat, rip roaring, horrible strep throat. They did a rapid test, which are notoriously wrong a lot of the times, and they never did a culture. And they said, "Oh, rapid test negative, send her home." And then she got incredibly worse over the next day or two. She's completely incapacitated. I'm like, "Well, what did the culture show?" And she's, "Oh, I don't even think they did a culture." I'm like,
Yeah.
right. And so she ended up with 2 urgent care visits to finally get treated properly. And she recovered. Luckily, she didn't have any major consequences from that, but she was sick as a dog way longer than she had to be.
Mhm.
Right. And it's just bad
It's
care.
bad care,
Right.
and they
Whereas,
usually where the patients end up after their urgent care visit, they're back and trying to get into their primary care doctor, right? It's like they're either back in
right.
urgent care, back
Right.
in their primary care doctor's office, or sometimes in the ER, right? It's usually it's like you can't just do one urgent care visit for a lot of things.
Yeah. A lot of
Yeah,
times,
there's
no.
you
Yeah.
don't get that answer the first time. I've had a lot of patients who will have to go multiple. They have stories of requiring multiple visits, and it's not even clear that it was useful, right? And so it's nice to be able to take that off the table and be like, well, I am the urgent care, I am the primary
Exactly.
care, the chronic care, and so you don't have to like.
And most of the time, those visits aren't fully covered anyway. So they're ending up paying for those or in some
Mhm.
portion. So, I mean, if you add up the cost of that visit plus getting there, parking and all the things, it amounts to like money that they could have spent on someone like you, right?
Mhm.
I'm sorry, I'm very cynical. You can tell I'm very cynical about this topic. Yeah. So you don't need to tell everybody your
Yeah,
pricing necessarily, but so people pay. I'm just going to ask you a couple more questions about your practice, if that's okay. Then we'll talk about hormones. Okay. So people pay monthly fee and they have unlimited access to you. Is that right? By
they
email,
do.
text,
Yeah.
video, in person,
Yep.
all of that. Okay. All right. Well, very
Yep.
cool.
Yeah. I mean, I know that people cannot exhaust themselves with the unlimited
Right.
as a
Right,
messaging.
right,
Yeah.
right.
No, it's as much as we need.
Got
Yeah.
it. And do you see whole families too, or mostly just adults? Since you're trained in internal medicine, I would think you'd just see adults.
No, I'm an internist, so I'm only trained in adults. So 17 is kind of my use
Huh.
that I'm comfortable doing.
Okay.
However, families in that regard, like a lot, or like adult or parents, and it's or I guess adults and then their parents. So
Uh-huh.
depends who's joining. So I have quite a few that I
Right.
love that. Like it's really so no young
Hmm.
kids.
And there are some direct primary care people who do kids too, if they're like
Absolutely,
a family practice kind of person.
direct
Hmm.
family medicine.
Hmm. So I know one of the really big areas that you cover is hormones for women and menopause, both of those things. So it seems one of the latest hot topics in medicine in our society are hormones and menopause and that traditionally doctors really have just ignored this topic and all these women have suffered unnecessarily. I think that's sort of the topic of a lot of podcasts and a lot of articles recently. So can you talk a little bit about what you've seen on that and what you do in your practice for
Yeah,
hormone treatment?
absolutely. Yeah. So I have been doing women's health as kind of like a sub area in practice my whole career. And right. And we're in this big moment of like shift and transition. And so I'd say that if you working with a doctor who cares is the most important because a lot of us didn't get training, right? I went through even through primary care and internal medicine training, talking about menopause was like barely mentioned. Maybe we had one lecture and then med school people hear this. Zero. Like I think there was zero
Hmm.
talk about this at all. I had heard of the Women's Health Initiative, though, of course, which is a big study, which I'll mention. I knew some things about hormones, but how to treat and work with someone through a perimenopause and menopause transition really comes out of just like an interest in working with women. And I was working in the women's health clinic at the VA, so all of my patients in that clinic are women, and we did a lot of hormone management work side by side with gynecologists, and like you get a lot of experience on the job and personal education so that you're following the guidelines from the American Menopause Society and the American College of Obstetrics and Gynecology. And so there really are these evidence-based treatments that nobody was really doing or didn't know how to do that or incorporate into practice because they hadn't been trained properly, right, to
Well,
do that.
and you mentioned the Women's Health Initiative study. So, that has been basically debunked when it comes to breast cancer. And so, but what happened was, I mean, I have talked to one menopause specialist on the program before. And
Mhm.
so I'm not going to quote the right data probably myself, but basically that initiative that came out in 2002. And there were some conclusions from that should never have been made because there was no data to support it. But they published it and they never retracted it, basically. And so for 20 years, people went off of that, not recommending hormones because of certain risks that actually were false. The bottom line was it really did not increase breast cancer risk the way they said it did or they interpreted it to do. And so for that reason, many people were not treated with hormones anymore for a long, long time. And then also the fact that it protected heart health and bone health was sort of like glossed over in a lot of ways, right? So, and so in many ways it's having this giant resurgence now, or it's not, I wouldn't say it's giant yet, but I do think it's going to be giant.
Yeah, the
Um,
pendulum has definitely swung, and like you said, we had this 20-year lull where doctors were basically told, "Don't prescribe this because it's gonna increase risk of breast cancer."
mhm,
When you actually look at the data, it was headline worthy.
mhm.
It makes a better headline to say hormone therapy like increases your risk of breast cancer by 50% or something like that. But the absolute numbers of breast cancer and the absolute percentage points values were very small, but like statistically on a large population, you can find statistical significance, but you always have to think about what's the clinical relevance. Is this clinically meaningful and does it have to completely bar a very valid, useful treatment? No, it didn't. And I know that then they broke down, right, and looking at the populations, and it all mattered on who was being treated and when and for how long. And so
Well,
it's
what
much
they
more
found was
nuanced.
that the control group
Yeah.
had a low incidence of breast cancer. Not the treated group had a high incidence. So actually the control
Yes.
group had an unusually low incidence of breast cancer, lower than average. And the actual treated group did not. So like it was
Yeah.
completely misinterpreted, right?
Yeah.
And misrepresented to the public. I mean, I
Totally.
didn't know either. I mean, I was in practice in breast cancer and I mean, to find that out 20 years later is just, oh,
So
mind
yeah, it's
numbing.
like a gut punch. You're like, I can't believe all
Yeah.
that care we missed or the misbelief. And I do think, didn't the authors, I think they tried to publish something like to redact it or to like comment on that, but it just got totally missed. And about the actual harms and benefits those papers got all overlooked if they
Yeah.
tried.
Yeah. Exactly.
Yeah, I mean, the good news is that I do think the pendulum has completely swung back towards treatment. The bad news about it is that doctors may still not be trained, and so
Right.
people are seeking care outside of like an evidence-based health system because we all the problems we just talked about, right? Like care is so hard to get, can't get in to see my doctor. I'm not sure if I trust them because like when I go there, I don't get what I need. And so I get it. Like I totally understand why you would be seeking this care outside or through supplements or things that you're seeing online. And I do worry a little bit about that getting like women getting taken advantage of a bit. It's like a very vulnerable time. There's lots of
Hmm.
symptoms. It's confusing. And if you can't find someone to work with who has experience and can help you navigate that and kind of know you, I think that it's just ripe for it's just similar to the weight stuff, right? It's like
Hmm.
people can't find someone to work with their care. They do have a risk, I think, of falling prey to things that don't work. So I'm nervous about that. But I would say in general, there's so many valid tools, lots of treatment, and it's not hard. It's really not hard to work with women on this topic. So like all doctors need to be doing it, one. But if not, then getting somebody who actually has a lot of experience in working with women. The vast majority of my patient panel is or the patients that I have are women in their 40s, 50s, and 60s. So perimenopause through menopause transition is like all I do many days of the week. And it's nuanced, right? It's like everybody needs one-on-one. And I get people coming in with all sorts of stuff. I recently had a woman coming who was seeing a menopause specialist based out of Kansas or Oklahoma, like somewhere else.
all doing it online,
Okay.
all compounded. And she came to me being like, well, she had these symptoms. She valid to get treatment. She had sought this woman out or heard about her and was taking her prescriptions in the way that this provider has their online practice set up. And she was like, well, she told me like I have to take it like this, or I have to be on, and it was like a combination like treatment that were like compounded. And I'm always just really hesitant because I'm like, you could probably use your insurance and get coverage for like FDA approved covered treatment. But she was told like, here's the protocol and just
Right.
take this, and then and then I don't know if it's see you on the next video call in however many months or come back
Right.
and feed us. Or women are told like you have to see, they have protocols of you need to check these levels and do X, Y, and Z treatments, where it's not necessarily, it's a lot of non-guideline based care happening.
Right.
So
And I think for people at home, if you're interested in hormone therapy, so somebody online is pushing you to get compounded hormones. Okay. That means that you're going to pay out of pocket for, and it's not going to be covered by your insurance. And so sometimes you need something compounded because it's just not available otherwise. Right. And other times you can get the FDA approved one from a regular pharmacy and it is covered. Okay. And so anybody who's offering you something where there is a covered alternative, they're offering you this compounded thing that they sell because they're going to make money off of that. And so, not that there's anything wrong with making money off of that, but if it's costing you more for that, that's not okay. Right. Whereas, like we see in the weight loss space, right? People have been offering compounded drugs because it's cheaper and because the FDA approves one from the pharmacy is so ridiculously expensive, people can't
yeah.
afford that, right? And it's also not covered if you're just using it to lose weight and you're not meeting the criteria, right? So
Probably it's not covered unless you have diabetes.
it's not covered.
Yeah.
So in that case, the compounding is actually saving you a lot of money. But in the case of estrogen and progesterone, it may or may not be saving you any money. It probably is costing you a lot more money if you're going that route.
And often it's told because it's bioidentical that you have like that's why that it's better somehow. And I would say if a hormone is not bioidentical, it wouldn't work. Like the term bioidentical, I think just meaning they are synthesized hormones, right, that are sold as a medicine. But I think it's a bit of a misnomer that like getting it compounded is somehow like different, that it's not
Right.
also because it's also synthesized hormone, right? It's like the
Yes.
only real
It's the
identical thing
same.
is the hormone.
Yeah, it's the same. So it's the exact same hormone, whether it's
Yeah.
compounded or you buy it from a pharmacy.
Yeah, they're the same. So
Yeah.
that's a little bit of a brandy thing. And then there are some supplements that do have some evidence to be helpful for things like hot flashes and mood. And like when there's a very few, but there are some randomized controlled trials with supplements of things that might be useful, like black cohosh for hot flashes, ashwagandha for mood. But if someone's also trying to sell you on a supplement package or something, it's like they can get pretty expensive, or like trying to do that. Most likely that's not like there are other options that are really approved that have that stronger evidence that might help your symptoms more. So if no one's even bringing that up as like an alternative to supplements, I think that's another thing that I question. I think you can use both complementarily together, but you should be like, if the discussion is too one-sided, right? There's probably some sort of gain there. So I like to just have a very open-ended, I'm very transparent with all my patients about where there is or is not evidence and what we do and do not know.
Well, here's what I know. I'm 57 and I kind of wish I had gone on hormones in my 40s when I started to have symptoms, but I didn't recognize that it was perimenopause because I got my period like clockwork. So, and we were taught in med school, well, it's really when you start getting irregular periods or if you lose your period that you're hitting menopause, and you're only in menopause if you haven't gotten your period for a year, right? And so I just was like super regular. And so but all the symptoms, this night sweats and the lack of sleep and whatever, I just thought, well, I have kids, I'm exhausted, I'm a doctor. And so you blame all these other things. But I can tell you, for me, like you take estrogen, hot flashes go away, and you take progesterone and you can sleep. So I mean, I started taking progesterone. I mean, I don't have a uterus, so I don't need to take progesterone to protect my uterine lining. So for those of you at home who've been told that, oh gosh, I have to take both, I can't remember why, it's because if you take estrogen only for the hot flashes, but you have a uterus, then that will stimulate your uterine lining, and that's dangerous. It can grow too much and potentially you could have a cancer, right? So we never do that. We always balance that out with progesterone. And so you always take both unless you don't have a uterus. But for me, I'm like, well, I can't sleep. Okay. But as long as I take the progesterone, I can sleep. So like those things are just, it's huge. And I don't think that I understood any of that until I lived it. And then, of course, we could talk about testosterone a little bit, which I think is also interesting and important.
Testosterone is FDA approved for sexual dysfunction, or low libido is probably what most people would think about it. So I
Right.
do prescribe that for patients for that. It would be very much off labeled or to be used just for like perimenopausal symptoms.
Mhm.
And so, yeah, primarily that's what I prescribe it for
Mhm.
using it, but it can be part of the picture. I don't have too many people who come in on that, but often if there is some sort of compounded formulation they're on, sometimes it has estrogen, progesterone, and testosterone kind of like in the mix,
Oh, that's
is what I've
interesting.
seen. I don't know that. I think anyone would feel good on testosterone. Like, I think if I took testosterone, I would probably feel great. Get me back in the gym. So it does make people feel better. I don't know that that necessarily means you need it or should be on it. And certainly for the FDA approval, the approved version and using this for low libido is for women who are no longer are postmenopausal, so not
Mhm.
having children. Although I do think that's because it's traumatic. You can't be on testosterone while getting the potential to get pregnant is one of the big things with that. And there are some other FDA approved medications for libido as well for women
Mhm.
that I will talk with people about, and many people don't know because they don't have that conversation with their doctor either, because no one's asking them. So I try to ask all these things because these are important for people's life and their health, and we should be talking about it. And honestly, most, like, a lot of my patients come in their late 30s or early 40s, they haven't necessarily thought about menopause, but they're like, should I start thinking about perimenopause? And so we have this whole discussion, and then we may do nothing, right? We may not starting treatment, but they're like, I'm 39. Okay, now let's have a discussion about, you might go through perimenopause sometime in the next 5 years, 10 years. I don't know when it'll start. It's all very vague symptoms. So it's just like the more we work together, the more, and when we have those open conversations, they can start to pull things together. But maybe this is related to starting to go through perimenopause, because there is not a test that's going to diagnose it or tell us that you're going through it. We're just going to put the picture together with your symptoms. And so, yeah, most of my women who have probably, if they're over the age of 35, you've probably discussed menopause at some point.
Right. Yeah. I just know from now looking back, I
Yeah.
really wish I had had that conversation in around 40, because I didn't skip a period till 55, my 55th birthday. That was my gift. And I was like, oh, maybe I should look into this. And I will say my estrogen is a patch, and that's covered by my insurance. My progesterone is a pill I take it at night. That's also covered by my insurance. And if someone had knocked on my door and said, oh, by the way, if you think about this now, you could have 15 years of better sleep. I mean, I'd trade, I would do anything for that. Right. Oh my God. So I do think it's really important to have that conversation with your doc,
And
because it could
15
save you
years
a
of
lot of
like improving
heartache.
your 15 years of setting yourself up for delaying your bone density loss, and
Right. I
15
mean,
years of improving your future cardiovascular health. So often I have patients with no symptoms. So you had symptoms, Kate, but like I have a lot of patients with no symptoms. And I'm like, well, you're 40, like around 45 is when I start to be like, should we just start it for the benefits, right? This
mhm.
is part of the preventative piece. Like, and also I see a lot of women with IUDs. So it's like, we don't even have a period to go off of anymore, right? We're going by age. We're going by when maybe their mother went through menopause, going through what we know. And I think if you could be on hormone replacement therapy between age 45 and 60, which,
Mhm.
it's optional to, I would say, to continue after that if there's like benefits still to be had, but that's around the time we start to think about coming off. Can stay on it. Depends case by case. But I'm like, that's 15 years of like good treatment there.
Well, I'm already
Yes.
telling you I'm not stopping it. There's no way.
Yes.
Because
Yeah.
it's a low dose. It's not like it's not like the old HRT that everybody was on back when
Mhm.
I was in med school, right? Back
Yep.
in the day, everybody took HR2.
Yeah.
And so the doses now are much, much lower than that.
Yeah.
And the drugs are better. They are essentially bioidentical now. They weren't back then.
Yeah.
People were on Premarin and stuff.
Yeah. They're
And
much safer.
yeah, much, much safer. And And I don't know, like I might have been a better mom. I think I was a good mom. Okay. I was a good mom and a good doctor,
You
but I
are a
think I might have
great
been a
mom.
better person had I been a little less
That's
exhausted. I don't
yeah.
know. It's my
You
guess.
know, a lot of women tell me, I don't know if you've heard of this from Medicaid, but because I haven't started my period, I don't know, I'm so angry. That's a really common symptom that I think
Yes.
women don't, mood swings and being angry. And it's like,
Being angry. I've heard
because
that a
it's
lot.
a hard phase of life. Everyone in their early to mid 40s has probably kids in elementary school, like maybe middle school. And you're just like, ah, right? Life is hard. So,
I've heard people say, and this is not me because I don't have a husband, but like they hate their husband every month, right? And then they go on hormones and they don't hate him anymore.
yeah.
So like I just think
Oh,
that's so
that
funny. I'm
is
like,
really funny.
yeah,
Yeah.
there's
There's got to
definitely an
be a lot of
emotional
receptors
component.
in our brain or something that for estrogen, right?
Definitely
Yeah.
are for
Maybe
sure.
it's making those connections, those mood connections. No, I love that. That makes sense. Yeah, I think just it's great to just to have that conversation. So if you haven't had that conversation, find someone to have that conversation with who has experience working with women. And there's a lot of primary care doctors out there who do have the experience, but they're not like they may not be listed. But I would say usually if it is a woman or who's gone through menopause, she probably will know or personal interest.
It's
Not to say
amazing
that
to
men don't
me.
either. And if it's hard to, it is hard to find care. Like I get that. It's
It
hard to
is.
access the care. And so I'm always happy to see patients and talk with them about that process, but I can't see everyone. So I do try just being as educated as you can be and bringing
Hmm.
that to the visit and just like kind of demanding attention. Because if you're healthy, she had somebody bring this up the other day, one of my new patients. Yeah, if I'm the healthy patient, that's the one the primary care doctor's going to come and see me on this calendar, on the schedule. That's the patient I'm going to catch up on my notes on because I'm going to see that person in 5 minutes, right? It's like an in and out kind of visit because they're running an hour behind from like the complicated person. So if you show up and you're like, I'm the healthy 40-year-old who wants to talk about menopause, right? Or something like get your time in, come
Mhm.
prepared to have that conversation.
And I think that if you're doc, if you are in this position, if you're in your 40s or 50s and if you ask your doc, "Hey, I really want to talk about hormones. I'm healthy, but I'm perimenopausal and I really want to talk about that." Are you the right person to ask, right? And if
Yeah.
they're like, "It's really not my thing. It's not my area of expertise." That they should know somebody to refer you to who really is the right person. Nowadays, there are people in every town, I think, or every city,
Yes.
more and more. And so go ask your primary doc. And if your primary doc, most doctors really, we know what we know what we don't know. And if it's not our area of expertise, we should be able to refer you to someone who is. So I think that's like a really good way to go about it. I think it's really hard to do these online things because they're really also not getting to know you either. So, but I think that it's so important to do. I think that for the health of women in general, it's a really important conversation to have. I have to say also another plug for people like you is, how Steffi and I met. So Steffi's practice is in my neighborhood where Glow is. Actually, your practice is half a block away, right? I
Yeah.
found that out.
Few
I
down.
had no idea. And but the way I met Steffi is she does these periodic walk with a doc in the park right by my house. And she's like, I'm going to talk about heart health and come go for a walk in the park and ask me anything. And I'm like, oh my God, that's so cool. I totally want to meet her. And I went on this walk and all these women were learning about heart health and I thought it was fantastic. And do people in regular practice have time to do that? I will just answer that. No, they don't. They're not doing that. Okay.
There's no desire to connect with the community, right?
And this is about connecting with your community, connecting with people even if they're not your patients. And you might get a new patient out of that, but you might not, but at least you're establishing yourself as someone who actually does care, right? And I just think that's phenomenal. I really do. I mean, it's I mean, partly why I wrote my book and have the podcast is just to give back, to reach out to the community and talk about these things because I feel like people just don't know and they don't talk about it. And it's not a mystery. It's just that our system has evolved to be completely dysfunctional. And how do we make sense of it? How do we get something good out of it? And hopefully we're both trying to help make that happen.
Be part of that. Yeah, it's
Yeah.
such a privilege to be able to be like the community doctor, right? I'm like, this is old school
I
doctoring.
just think it's
This is
awesome, right?
it's so fun.
You
It's
hang
so
up a
rewarding.
shingle and people like stop in, hey, can I ask you? So,
Yeah.
Steffi, can you just tell people like how to reach you, how to reach your
Oh, sure.
practice?
I was gonna add to it. It's like in addition to the walk, sometimes I'll do like free talks. Like I've done them at some of the local gyms or like webinars and things. So if people are on my mailing list, if I'm giving a talk about menopause or hosting an event, that's how you can hear about it. I'm planning an event, a women's event, I think for end of May or early June. That it's not just for patients, so like it's anyone can
Yeah.
sign up. So I try to post my stuff when it's stuff like that for the community. It goes widely, but people can find me on, well, they can find me on Instagram and you can message me there, but I'm at Steffie Deeds MD. And then my website for my clinic is www.deedshealth. So Deeds is my last name, deedshealth.com. And that just talks about like my clinic and the different things I do and has a link to learn about how to join the practice, some freebies, some blog posts and things like that on there. And the signing up to be on the mailing list too, if you wanted to learn about events and things that I host.
We will have links, by the way, to all those things on the show notes. So
I do also have a menopause checklist link. These you can find these online, but this would be something that you should fill out. You could fill out and bring to a visit with a doctor to be like, here's the symptoms I'm having and why I think I might be starting perimenopause. And I'd say if you're between the age of 40 and 50 or 40 and 60 and you fill that out, or maybe you haven't gone through menopause yet, and you do that checklist and you feel like you're scoring a lot of it, that's perfect to bring in and have that help guide your conversation with your doctor.
that's great advice. And so,
I think it's linked on my website, but
we'll put that link in the
I
show
can give
notes
the
as
link
well.
in there so people can get it. And yeah, I like connecting with people, so I'm kind of an open book. So if you find me and you reach out, then I do respond. So
Well, I think it's been fantastic. I'm really appreciate your being on the podcast today. And I think there are a fair number of us physicians who we are that kind of person. We do like to connect and we do like to be accessible. And I think it's the system that builds like giant brick walls around us and makes it just impossible. And we're so buried in the chaos and the paperwork and all of that it's hard for people to get out of that. So for those of us who have escaped, you can reach us pretty easily. But I do think overall, I mean, there are a lot of doctors who really would love to be able to provide this care. It's hard. And it's hard to be on your own, right? There's a lot of risk in that. But I think
I'll dream big. We'll pull some more people out of the system someday here soon.
we are both dreaming big, I can tell you. Well, Steffi, thanks so much for being on the podcast today.
No, thanks for having me. Sorry for the technical difficulties. I should have just done it on my phone the whole time because that would like hurt the best.
That's no problem. I will figure it out.
Okay. Thanks, Kate.
Thank you.
Well, have a good rest of your afternoon.
If you've learned something and like what we're doing, please tell your friends and give us a 5-star rating in your podcast app. If you have a question or a crazy story of your own you'd like to share, please send an email or voice recording to info@drkatedee.com. That's DRKATEDEE.com. Or reach us through the website MedSpaMayhem.com. And read the book. MedSpa Mayhem is available everywhere books are sold. Thanks for listening. This has been MedSpa Mayhem with Dr. Kate D. We are so grateful you're listening, and we hope you've learned at least one fun or possibly disturbing fact today. Don't forget to hit subscribe on your podcast app and leave us a 5-star review. And read the book. MedSpa Mayhem is available everywhere books are sold. Links and more can be found in the show notes and on medspamayhem.com.